Physician Forum of India for giving me this opportunity to chair today's session. I have been given the task of introducing the speakers. The tallest among the orthopedics team is none other than Dr. Harshvardhan Hegde. We all know him. We have heard him many times in earlier talks also. And he is an excellent orthopedic surgeon. He does all orthopedic surgeries, but he has special interest in spine surgeries, vertebroplasties, kyphoplasties, and spine deformities. He does excellent work, and he had his initial education in Baroda. So welcome, sir. Then next is Dr. Niti Raj Oberoi. He is a Millennium, and he does arthroscopy and treats sports injury persons. Dr. Rakesh Mattoo is from Kashmir. He had his graduation from Srinagar, GMC Srinagar, and post-graduation from Jammu. And we'll be listening to his talk today. Dr. Akshay Saxena is the fourth one, and he also has special interest in spine surgery. So thank you, Orthopedics team, and welcome. Thank you.
Good evening and welcome you all, ladies and gentlemen, on behalf of the Orthopedic team, which has been just now introduced to you. So I will be talking challenging orthopedic infections. Bone infections have been seen to have changed in the past 70 years because of the advent of the newer antibiotics. The hematogenous osteomyelitis, what we see initially, is on the decrease, and the acquired form, the post-traumatic or post-operative form, is on the increase. Because of the rapid urbanization and industrialization, the accidents are more, and orthopedic interventions like implants and nailing and fractures is on the increase. So we'll see in future also that there will be increase in the secondary infections of the bone and joint. So talking about the incidence, in trauma surgery, if we do it in a closed fractures, so to say, the rate is between 1 to 5%. But depending on the severity of the fractures, like in open fractures, from 3% to 50%, depending on the severity of the injury. That means the Dustalo classification says that it is grade 1, 2 or 3, 3A or 3B. So here it is the severe grade 3B. This is a patient which we received in the emergency just a few days ago with compound T3 fracture and injury. We are seeing there's soft tissue and skin disruption, there's periosteal disruption and fracture with contamination. So these type of fractures should be dealt immediately, and they should go to a hospital or a center where immediate care can be taken with multimodality approach, because such type of injuries need the interventions by orthopedic surgeon, the plastic surgeon, the vascular surgeon. This is what we did initially. So immediately this patient came to us at 10 o'clock, and by 11:30 he was in OT. So we have to treat such fractures within 6 hours of injury, so that what I'm going to talk about, the chronicity of the infection, that can be prevented. So we nailed him, the plastic surgeon came and he grafted. So in arthroplasty, the primary hip and knee replacements, early infections are expected to be between 0.5 to 2% of cases. In revisions, which are non-infective, deep infections occur in 5% of cases. And the incidence of infection registers 20% in already infected replacements. So In short, the chronic osteomyelitis or chronic bone infection is a surgical disease that requires significant dedication from both patients and surgeons to eradicate, because it's a very tough thing to eradicate infection. And patients are fed up, even the doctors are fed up of treating these infections. It needs a multimodality approach. In the association of orthopedic surgeon, the plastic surgeon, vascular surgeon, all have to work in tandem to treat these patients. This is a picture of a chronic osteomyelitis patient with proximal tibia involvement. You can see the draining signs, the adherent scars. And puckered skin and skin changes. So there are some patient expectations, and what we have to counsel these patients, because the treatment is long term and it is very arduous. So multiple surgeries are to be done. The patient has to be counseled that you have to be very patient so that he cooperates with us. And there are also financial implications involved with it, because these patients can be with us for many months or even a year. So the patient cooperation is very important. So in short, what are the issues what we face with the chronic bone infection? Once there is a chronicity of the infection, this infection is walled off. The infected tissue is walled off with a fibrous thing, which prevents the vascularity, the new vessels, so that these, if there is low blood supply, so there is poor penetration of the antibiotics. So infection cannot be eradicated. Also, another problem is dead space, because if there is infection, bone loss, there is a space left, which is also a chronic source of infection. So we have to manage this also. It's very difficult and very important to manage that dead space. Also then, if there is fracture, then there is instability, because instability will always lead to more and more infection, because it won't cure in spite of everything. So we have to take care of that instability, we have to stabilize the bones. And because of all these issues, because of long drawn treatment, there is loss of function. The adjacent joints become stiff and they are painful. There are many methods of treating, but over the years people have tried many systems, vascular grafts, the non-vascular grafts, simple bone grafting, and Elizaro technique. Many of you must have seen the Elizaro ring fixators. But like this fixator, it's a bulky thing, and one has to wait for even years for bone union, and there are other implications of pin tract infections, neurovascular infections, implications. So now we have started a new technique, the masculine technique. It's a newer technique on the block. So this technique offers a very viable management strategy for management of large bone defects. Like the simpler techniques like simple bone grafting and other things, we can do it in a defect of 4 to 5 centimeters. But more than that, if we do that routine things, it gets absorbed. The graft is resolved and there is failure of union. But with this technique, the method is a relatively new method, and it addresses the bone defect larger than 15 centimeters. And even up to, they have seen that it can be done up to 25 centimeters of bone loss. Mascule started his work in 1986, and over a period of 20 years, he took almost 84 cases, when he published this first article in Orthopedic and Traumatology Journal in 2012. When the world came to know about this technique, and people have started doing this later on. So it is divided into various stages. So stage 1 is radical debridement. So this is very important, because you have to be ruthless about taking out the infective tissue, the bone. Whenever there is infected bone, it has to be excised. And after excision, one has to do burring until the end. Once there is those red small dots appear in the bone, which is known as paprika sign. So then we are satisfied that yes, it is now the viable bone. In case where there is soft tissue defects, we have to take help of the plastic surgeon to do the soft tissue flaps, repairs, to increase the vascularity of the local area. As I told you that because of the instability which has to be taken care of, so we have to do limb stabilization with nailing in diaphyseal fractures, in bone losses, or plating when it is towards the metaphysis, or we can use even an external fixator if it is towards the joint. Also, dead space management can be done with the cement, bone cement, polymethyl methacrylate cement spacer, which can be mixed with antibiotics, and that is to be filled into those bone defects. And usually we put gentamicin and vancomycin. We mix it with the cement so that locally the antibiotic concentration is increased. After doing this, if there is still some discharge from the wound, we can use this vac device. This is a vacuum assisted device which has a motorized system. It helps in two ways. It sucks out the remaining part of the infective material or discharge, and also helps in granulation of the tissue. The philosophy of Masculine. There's an induced membrane, which is a foreign body reaction to what we put inside that cement space. So over that space or over a period of time, a membrane is formed which is very rich in those tissues. It's vascular and growth tissues. It's very rich, and this membrane is synovium-like, and the epithelium is vascularized. It has growth factors in high concentration. These are the growth factors: BMP2, TGF, beta-1, and BGE. Also, it acts as a biological chamber for bone graft, which we have to do in next stage. It forms a chamber which is richly vascularized and full of these growth factors, which helps for the consolidation of that bone graft and union. So this is a case which came to us. This is a person with chronic osteomyelitis. This is the draining signs. You can see this puckered skin and scars. He had been operated thrice previously. And once he came to us, this was the picture, the X-ray picture, with a gap in between and infected gap normally. So on taking it up surgically, so the bone was excised, the dead bone was excised, the tissues, infected tissues were taken out, and you can see the gutter right up to the metaphysis, because this was all infected and it was burned out. And this was per of picture of the bone after stabilization. This is we have stabilized it with a locking titanium plate, and this we can see the gap has to be filled, and it has to be covered with the soft tissues. So this is the picture post-op. You can see the screws going even through the cement. So it stabilizes the whole thing. And this is the once we closed it in layers, so that later on this is the end of the stage 1. Then of course we have to start with the antibiotics and other things. So between stage 1 and stage 2, once we have to do stage 2, we give a gap of 6 to 8 weeks. In this time, we have to start the antibiotics, the appropriate antibiotics. We have taken some culture sensitivities and other tissues for antibiotic sensitivity. And as per the reports, we start those antibiotics. Usually, we do 3 weeks of intravenous and 3 weeks of oral, till the time that infection is over. So, also this time is important for epithelialization of the tissues, a flap if it is done. Also, it helps in the revascularization. This is important, the formation of the induced membrane, periosteal membrane, which is very important for us. And of course, the healing of infection through systemic antibiotics and also the local, what we have put in the cement. Now comes the second stage. After we are sure that the things are quiet and we monitor through the clinical examination as well as some ESR, CRP comes to normal levels, then we take them up again, remove the cement spacer, put the graft inside. We take good chunk of graft from the iliac crust, the spongy, cancellous graft. Also we can take graft from the condyles, the femoral condyles. We can take it from the same femoral condyle. We get good amount of graft. And then closure of the soft tissues. This is the second stage now. The first stage is over. We can see the plate in situ, and this is the cement spacer stabilized. This on opening, you can see this cement spacer here, and this part of membrane is incised carefully so that we have to again close that. And cement spacer is removed, and you can see this whitish membrane and good vascular tissue. This is, then we have to revise our this stabilization. We put the plates stabilized, and this is the bone graft. This one, the good chunk of corona impacted inside that dead space. And we also have that bone marrow aspirate. We can also inject it to promote healing. This is the X-ray picture, well aligned. After 2 weeks, removal of sutures, and then you can see this man with the brace. Then infected arthroplasties. So infection can be in bones because of trauma and other things, but because of more and more interventions, arthroplasties, so they are also bound to be infected in some number of cases. It has its own group of challenges. We have to be very, we have to do adequate investigations before arriving to the fact that it is infected. So we have to do clinical, radiological evaluation, see that there is, look for the signs of loosening, extensive debridement as the routine thing, which is important, removal of implants, and again the antibiotic impregnated cementation. And we have to, there is one issue of instability because we cannot do much of bone resection here because of the attached ligaments. So we have to be very careful about that also. So this is a 65-year-old lady which had been operated thrice. Initially knee replacement done, got infected, then again revised, and then this is the stage when she came to us. You can see that this whole implant, the bone is reabsorbed and the implant is loose. She was in agony, pain, swelling, and she could not even move the joint. This is on opening of the joint. Every implant was removed. Debridement was done, and these are the implants which had been removed carefully. Although the femoral component was loose, this was already loose, and we had to take it, the tibial component, very carefully. And then after thorough debridement, we had to make this cement spacer. Shape one man has to put into the tibia, make this space so that the gap is maintained, and then this is the post of X-ray, how the cement is placed. Then this is the next stage, after 6 to 8 weeks. But in this case, we had to slightly wait for longer time, 2 months, 2.5 months. Once the infection was cleared, then we again opened, took out the spacer, did some again with the debridement, and this is this is a fully constrained implant we had to put. This is. She had recently come to the hospital for some gastro problem. This is after 5 years of surgery. We had done previously, and now see, you can see her the knee movements. The scar is good, and she has a straight leg. She can walk normally. This is another case, a 75 years old female. The initial X-rays, what we could retrieve from her, that knee replacements are done for this, the primary knee replacement, done somewhere. And then down the line, after 1 year, she was infected, and she went to some place and got it revised. Because you can see this is absorption of the bone, it's all infected. So you see, here comes the importance of radical debridement. You see, he has put this femoral implant there only. They only took out the tibial implant. So she again landed into trouble, and after that she was in pain with a lot of instability. You can see the valgus instability. This was quite inflamed, painful. So we had to revise it. And this is the first stage of the surgery. This implant, femoral implant, it was loose. You can see the osteotome being introduced inside. It is because it was totally loose. After taking out the implant and doing some debridement and putting the cement space, the femoral and the tibia. This is the post-op. 3 months down the line, once she was absolutely cleared of the infection, this is the thing which we did. Fully constrained knee implantation. This is 6 months down the line, clear scar, no inflammation. This is, she's sitting comfortably and she can walk and stand normally. She lives a normal life now. So the key message is that chronic musculoskeletal infections are multifactorial origin, and so interdisciplinary collaboration is required for the treatment of success. To be successful, the goals of treatment are long-lasting, arrest of the infection basically, and pain reduction and restoration of function. Surgical debridement is critical to the success of the treatment in both post-traumatic or post-interventional osteomyelitis, and in specialized centers, infection arrest is achieved up to 95% of the cases. Thank you very much for the patience.
It is open for discussion, comments, and questions.
After arthroplasty, though the PGI incidence is less than aseptic loosening. How true is that, sir? And probably it's less than the aseptic loosening, which is a good thing. Because aseptic loosening probably doesn't need antibiotics or debridement. So here you need to do that.
We can do that in a single stage.
Right,
When
sir.
infected, we have to do it in a double stage procedure.
So what would be the incidence? About 2%?
Of loosening, aseptic
No,
loosening.
sir. Of infection, PJI.
Post-primary joint.
It is about
I'm talking the periprosthetic joint infections. PJI is a periprosthetic joint infection. So, about 2%? The best of centers, 2%? That's as far as the knee and hips are concerned. What about the elbow, which is about 10%? And why would that be so?
Because in elbow, the loosening is more because of the
Probably you need to do multiple procedures in elbow.
Before
See,
you do
that,
that.
yeah, that's why it's about 10%.
Primary osteoarthritis of the elbow is where?
no, because also the elbow replacements are far lower than the other replacements, hip and knee, and the anatomy is very
Right.
subcutaneous.
Absolutely, sir. You too. So let's talk a little about the acute infection. The biofilm can be eradicated without removing the implant.
No,
In acute infection, sir, the
Yeah.
biofilm can be removed without removing the implant. Can be treated without removing the implant.
initially, if
Yes, in
suspect-
acute infection,
Yes,
sir.
in acute infection,
Right.
if it is detected within 2 to 3 weeks,
Absolutely, sir.
then we can do again a rewash and we can change the poly. if you like.
Right, sir, right. So, what would be the modality of identifying infections? Would it be synovial fluid aspiration culture,
Yeah.
or would it be probably a sonification for dislodging microorganisms from the processes and culture of the sonification fluids, or would it be imaging? Tell us about the PCR also, sir, for identifying the infection.
Actually, there is no single method we
Right, sir.
can rely on.
Absolutely,
So
sir.
we have to do a multi-modality approach.
Right, sir.
Clinical, radiological, the blood investigations, and all have to be correlated.
Right, sir.
And most important is clinical.
Absolutely, sir. So, orthopedic device related infections are successfully treated with debridement and antimicrobial therapy. If the pathogen is susceptible to rifamycin, which is gram-positive bacteria, probably, and ciproflogram negative. What about the MRSA infections? Implant need to be removed? Dr. Mattoo?
Yes.
MRSA infections,
Yes.
the severe infections, implant
Yes.
needs to be removed.
Yes, yes.
Great, sir. So we studied 40 years back that calor, dolor, rubor and tumor
Yeah.
was the essential quartet. That's true today as well?
Yes.
Wonderful.
Very much.
Very much. 40 years back we studied, it's true today as well.
Not even 40 years, it is since hundreds of years.
I studied 40 years back.
No, there is one more, no? Loss of function. Function is.
Oh, that is fifth one.
Thank you, Dr. Vijay. And so what else? Some bacteria may remain and colonize in spite of perfect debridement and colonize. So probably what do you do?
That's why then we cannot say 100% eradication.
Right.
We still are at 90%. We have
90%. So well said, sir. Sir, a little about the antibiotics. Do you start empirically till you wait for the culture to come?
Yes, of course.
Yes.
We have to, once we start in the first stage, we take the culture sample. It takes around 72 hours, 48 to 72 hours.
So do you wait for 72 hours or will you empirically start?
Empirically start.
Right. So if you start, what do you do? Clindamycin or linezolid or vancomycin?
No,
What do you start with? Beta lactam antibiotics? What do you start with?
Clindamycin, because it has
Clindamycin.
good bone penetration and
Absolutely.
also linezolid.
I'm glad you said that. Yeah, wonderful, sir. Finally, what about the impregnated beads? See, like tobramycin or what else? Gentamicin.
You see,
Impregnated
yes.
beads for the dead space.
Initially beads were put, but it did not form a good biofilm.
Right.
This membrane, the
Right.
reduced membrane.
Okay.
So a cement spacer which is in the gap, non-linear, so it forms a well-formed membrane which
Right.
can be incised. So beads did not form good membrane.
So you no longer use these beads? No.
We used to do those small beads, make and put thread into it or
So
stainless steel wire.
tobramycin, gentamicin, vancomycin, no longer use the beads?
We use
Locally.
usually vancomycin.
So that's systemic.
Let me
Yeah.
answer it.
Yeah.
So your question is, why were the beads used? So we'll go back to the question. The first thing is that we have to create a space, which means a thorough development. I'll answer all your questions. Once you're putting the bead inside, you have to also remove it. You need a structure which encourages formation of a tubular film inside which, as a subsequent procedure, is for bone graft. And the beads were not doing that. So in smaller, more contained infections where there is no intercalary loss, we still use beads, or we use collagen impregnated antibiotics.
I was talking about the dead space which you
Dead space management through beads is not a great idea.
No?
No. It is better to do it with a block of cement. If it is a contained space, means it has bone on all sides. Then it is better to use a collagen implant rather than a bead, because it obviates a second procedure.
Okay.
You don't have to go back and remove it.
Right.
Because removing the bead is also a surgical procedure.
Good you said that. Finally,
It is important to me
Absolutely.
for years
yes.
and he is fed up. And we are also fed up.
Right. Thank you, sir. Thank you so much.
These are the people who do
So, just a word on that, sir, please.
spinal surgery. But I saw your list of talks that have happened over the last few years, and I realized that infection is something in bone, and that too challenging infection. These are patients who had come to us with an idea of amputation. That's why we didn't talk so much about joint replacement, because it has been talked about many times and now more or less established.
Maybe next time, sir.
Definitely, then Dr. Oberoi or Dr. Mattoo will be very kind to talk on knee replacement, because they love doing that.
Love to listen to that.
Yeah, so we will definitely discuss that. But we thought this was an interesting, slightly out of the way and more challenging. Less in terms of financial, and more in terms of gratification, in terms of surgical excellence. So we have, you can't be having 10,000 cases of infection of bones. We would have 10,000 cases of knee replacement. So we're doing knee replacement almost every day, 2 or 3. But we decided to talk on this. He just touched on the area of infected joints. So Dr. Mattoo and Dr. Oberoi both do joint replacement, especially of the lower limb and of the shoulder. So, we had touched on this elbow. It's a very interesting question. Elbow fractures and malunion is the reason why most of the times you do it. Elbow replacement. Rarely do you do it for primary osteoarthritis. It does not happen. So these are already invaded tissues. So that's why the chances of infection is slightly higher than this.
Than hip and knee.
And then hip and knee. And also I think experience in hip and knee has made us much smarter, whereas elbow is less frequent.
Absolutely.
So we are still to master it to the way that we have mastered knee. For example, in our center, we rarely see infection. This is statistical, 0.5 to 2%. I think we have studied over 3,000 joints done between us in different hospitals. In Escorts, we are happy because the operation theatres are first rate. You can close your eyes and do the surgery. That's so good. And in every sense of the word, central, laminar airflow, exponential exhaust, the OTs are large, we have all the systems in place. So it is going to give us much higher success rate. And we don't touch 2. We are, I think, less than 1%. Yeah, we are doing very well in that. Also, we don't have DVT because we follow them up very well and put them on physiotherapy and things like that. So next time we'll definitely talk about
looking forward
to joint replacement, and it will be Dr. Mattoo, Dr. Oberoi who will be doing the training.
Very informative.
Dr. Mattoo, thanks. The CD4 is less than 200 and they have secondary infections. So, if a patient comes to us and if he is having bone TB, so what will be the recommended test you will recommend the patient to do at the early stage so that he is able to detect that early in HI patients?
in tuberculosis, it's very difficult to diagnose. It has also been a multimodality approach. But MRI, number one, but biopsy of the tissue is the gold standard.
No, sir, but if there is a bone bleeding, yeah,
Bone tissue,
yeah,
biopsy.
we can do a biopsy.
Yes.
What will be the, जैसे पेशेंट आपके पास आता है तो उसकी क्या इंडिकेशन होंगे, क्या आपको बताएगा कि डॉक्टर साहब मेरे को यहाँ पर दर्द हो रहा है या इन्फेक्शन हो रहा है या परेशानी हो रही है या वेट लॉस हो रहा है?
Start with the investigation. All the blood parameters, you have to see basically first the X-rays. If we find something in that, the early changes, like the soft tissue planes are obliterated, there is some change in the bone, cyclosis, or ramification, and then we go for MRI.
डॉक्टर मोटू, अभी हमारे जॉन साहब कह रहे थे कि आप एक क्वेश्चन टेस्ट में पूछ लीजिए. हमारा से डॉक्टर विनोद राणा, थैंक यू, यू हैव बीन ऑन आवर प्लेटफॉर्म. This is what आप क्वेश्चन पूछो, कैसे क्वेश्चन कि you are on live on Facebook and I have got 5,000 friends and 75,000 followers on Facebook. तो मैं एक क्वेश्चन पूछना चाहता हूँ, मुझे जैसा आप क्वेश्चन पूछो तो है कि अगर किसी सीनियर पेशेंट आईसी कठिन दौर tennis कितपत करोस डायग्नोज की tennis कठिनस प्रॉब्लम या मस्कुलर
Certainly, those aspects we have to. Okay.
Sir, please speak in Kashmiri. Yeah.
What happens अस्पतालों के clinically examination के set of questions and then investigation, like blood tests, X-rays are important. But MRI, अगर तुम cartilage defects या bony deficiencies, or you have to segregate osteoarthritis and what do you call it?
Thank you, sir. Thank you, sir. God bless you, sir.
Sir, it's not wrong.
Be after trauma or they can be after surgery, and it has to be tackled like a team and multidisciplinary approach. And if done particularly, then success can be more than 90%.
Man and myself both are in pink.